Everyone, today we have a special guest, Soke Langman, who is a professional kickboxer, retired professional kickboxer. He's an old guy like I am now. He still teaches at Black Lotus kickboxing in Aurelia. Now, Sensei's come to us with this right Achilles pain and left knee pain. And when we did the initial assessment, his posture is his fighting stance. So he's rotated slightly to the right and he's slightly elevated. So essentially he's always standing in his fighting posture. So we have this right rotation on the left, and we got tension on the left and compression on the right. Now, when we checked myotomes and we looked at his dura, he's trapped from C-spine all the way down, right? So if we look at kickboxers, they kind of got this tucked under position, and they're always twisting and striking on top of that. If they start getting stiff in the hips or in the T-spine, anywhere where they have to rotate, that dura might start getting compressed. Now, when we did the myotomal sensitization testing, we saw two different things happen. When we dropped his head into extension on the right, we lost L4-5 on the right. When we flexed his head and put tension through the dura on the left, we lost L4-5 on the left. So we have two different things. And it kind of makes sense because his fighting posture is kind of this right rotation and to the right, so we're compressing and tensioning here. So we went after some dural mobility. We went after some C-spine stability because he always gets jammed. He likes to get punched in the head sometimes. So we're going to have to check that again today because we're a little bit compressed. And then we're going to go after some of the dural mobility, but also we did a lot of spinal rocking and rolling to strengthen and teach that dura how to stretch. So we're going to go through our global movement scan to start. So Nick's going to stand with his feet together. We're going to bring the chin down to the chest. And you can see he's not quite getting there. So we're almost just over 2 fingers, and he's got this myodural bridge. Okay, so I'm going to just stand here. Okay, so when we see this kind of rope pop up here, this is called myodural bridge. It's an indicator that there's possibly fascial and dural tension. We don't know where, but we just know that it's there. Look up towards the ceiling. Any pinch, pain, pull anywhere. Okay, we're looking for hinging, any compression, any excessive. We're looking for 10 degrees to parallel. We are a little bit restricted with that. You need to turn face this way. Turn your head to the right. We're looking for that 90 degrees rotation. Can you get chin over collarbone? Left. That looks pretty good. A little bit of a chin poke on this side, so a little bit different. And then we'll look side bend, so roughly about 45, and switch sides. Any problems with that? Any pinch, pain, pull? Just tight. Just tight. Okay. So feet together. We won't go through the upper extremity. We know that moves pretty good. Bend forward, touch your toes. So he's got a really nice toe touch. Bends quite a bit through here. Gets a little flat, but overall pretty good. Any tension on one side more than the other? About the same. About the same. Good. Come on up and go arms up overhead, or do global extension. Okay, we're looking, can he get the pelvis over top of the toes? Any pinching compression going on in here? Not too bad, nice. And then we'll keep the arms up, and we'll side bend to the right. Okay, and then we'll side bend left. And what I'm looking for in the back of the spine is, can he side bend through that lumbar spine, or is it hinging and twisting? It's actually pretty good. Arms out the side. Lastly, we're going to global rotation, turn, turn, turn. Now we want to see 100 degrees of rotation, so I should be able to see the shoulder. But I want to see about 50% of that rotation happening from the pelvis. So lots of rotation happening here. Pelvis, not so much. Go to the left. And you can see this side's quite a bit different. And I can see this shoulder much more effectively, and the pelvis is going around. So we have this right rotation restriction, but we don't know why yet. And lastly, we're going to go into single leg balance. Okay. Anybody who's in a contact sport, we don't want to assume that there's no concussion type of stuff or top-down control issues. Close your eyes. 10, 9, 8, 7, 5, 4, 3. And he's doing a little bit of a dance here. That's okay. Eyes open. And we'll stay on the right leg. Find your balance. Nice and tall. Close them when you're ready. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. So a little bit better on the right than the left. Okay. So we don't know why yet, but we do want to do a quick cerebellar scan. So we're going to do one foot in front of the other. And this was clear last time, but because Nick took a little shot to the head, it might have set something off from a cerebellar perspective. So line up the feet, arms up, zombie arms, and close the eyes. 9, 8, 7, 6, 5, 4, 3, 2, 1. Good. Other side. So we want to see and make sure that he's not falling to one side, okay? And we do switch the feet because it could be a proprioception problem. Close the eyes. If there's consistency of fall to one side, then we have to look deeper into the cerebellum and see if there's any problems or disconnections with the visual vestibular system or the proprioceptive system. So Scharffen-Romberg is nice and clear. It's just on single leg balance that was a problem. So we're going to look into more of that. Now, come on down, have a seat. We'll look at the slump test. So we're looking at central neurodynamics. So we're going to bring the hips and knees to about 90. Feet together, hands behind your back. Good. Bring your chin to your chest as far as you can go. And we're going to curl all the way down into the spine. Good. Any pulling, any tension with that?
Nope.
No. Slowly straighten your right leg with the toes up towards the ceiling. Any pulling, any tension there?
Back of the knee.
Back of the knee, okay? So now we've got tension. We're putting stretch for that full dura on the sciatic nerve. So Nick's going to look up at the window. Does that make it better, worse, or no different?
A little better.
And you can see he can straighten the knee. So we know that when we release tension at the C-spine, it releases pressure off the dura. If we come up through the T-spine, it gets a little bit better. Come up through the lumbar spine, and it takes tension off. So we can say, okay, we do have some central entrapment. It's just not sliding up and down. Okay? If we go left side, we'll see if there's any difference. Sometimes, left leg up. Tension, same deal. Okay, look up. Better, worse, no difference?
A little better.
A little better. Come on up. A little better. And come on up. If there's a specific area of entrapment, then it typically pops up. So if there's no tension or entrapment at the C-spine, all of a sudden you're like, yeah, I don't feel a difference. And if there's entrapment in T-spine, all of a sudden, ooh, that feels different. So we know that we need to get the dura to at least start sliding a little bit better through the T-spine. We'll go arms across our chest, legs together. We want to look at rotation. Go to the left. And we saw in standing, Nick's rotation was limited to the right. Go to the right. So we're looking for 50 degrees and a little bit restricted. And you can see on his face, it's not easy for him. Now, can I take him? I can take him a little bit, but we do have some restrictions going on here. Okay. So it's not just the hips. Okay. Lay down on your back. We're going to go back and check the myotomes in the lower extremity because those were affected. So we'll do an active straight leg raise. Lift this leg straight up in the air. Good. Go back down. That one. Go back down. Feel about the same? Feels about the same. Good. Looks the same, feels the same. Great. So we're going to go, we'll test in neutral first. Okay. So we check our myotomes. We're going to check L5. Push the toe up towards the ceiling. L5. Push the toe down towards the floor. S1. Foot up towards the ceiling. Kick up. L4. Kick up into my hand. L3. Hold the leg. L2. Hold again. L1. Let the leg relax. We'll just check L4, 5 again. Don't let me twist. Nice. Good. Okay, so nice and strong over there. Compare to the other side. So this is testing the neck in neutral. Big toe up. That feels different. Big toe down. S1 strong. Foot up towards the ceiling. Push up. L4 feels a little different. Kick up into my hand compared to the other side. That's fine. Hold the leg. L2. Hold again. L1. Check the hip rotators. L4, 5. Okay, so that feels a little different. Now, coming back to what we saw in the posture. Okay, head is slightly rotated to the right. And we also take where did you take the hit?
This time it was right on the chin.
Right on the chin.
Yeah, last time was on the left side.
Right. Yeah, it kind of whipped you probably back and to the right. So we're going to drop the head into extension. See if it sensitizes some of the myotomes that we are kind of suspecting down below. So we kink the hose, right? Because it's one big long tube. We're just made of a series of tubes. And we push the big toe up. And it starts to fatigue. Okay, so we sensitize L5. Push the toe down. S1, foot up towards the ceiling, push up. Okay, it's about the same. Kick up into my hand. L3 still strong, hold. L2, hold again. L1, good. And hold the leg, let me twist. Hold. And L4, 5 in the deep hip rotators is fatigued on them. Okay, so when we kink the hose and we compress, it sensitized the right side, L4, 5. Now we saw that there is tension in the dura, and it's coming from C-spine all the way down the lumbar spine. We'll check both sides again. Now I know the response to this because we found this last time, but it could change. Big toe up. It feels different now. Big toe down. S1. Foot up towards the ceiling. So now we put tension through the dura, and it could be tugging lower down and affecting the myotomes in a specific way. Good. Hold the leg. So this is better. So the last time we tested this, when we put Nick's head into tension, the L4, 5 on the left side shut down, and the right one got better. Okay, so I'm just going to push up. No, didn't change it. Great. Okay, So that's starting to clear up things on this side. Come back over to this side. Let's see what happens. Big toe up, big toe down. Good. Foot up towards the ceiling. Good. Kick up into my hand. Good. Hold the leg. Good. Hold again. Nice. Don't let me twist. Hold. Okay. So you can see things turn on better when we open up the right side. So the left side tension was more of an issue last time, but I know he's doing his homework exercises. He's doing the neck stability exercises. So it's not sensitizing this side enough, causing the issue. So now we can focus more on the right. Now we're going to look at the neck because it took a shot on the chin, and we want to make sure that joints are moving like they're supposed to. If there's any restrictions, we can compare our flexion rotation test to make sure the AA joint is rotating. We go rotation flexion. You can see he gets a little grimacy on the face. There's some muscle tone there. Okay. So there is more tension on the right side here. So this is where I'm going to want to do some manual therapy to reset and change the inputs on this right side. We'll check the joints to see. He's a little bit jammed up, kind of around C3, 4 on the right side. Left side feels pretty good. So if we do a little bit of muscle releasing over here first, take away some of that tone. And I like using positional release therapy if there's any trigger points. So it's allowing the body to kind of settle down. It's less direct, and it's allowing the body to unwind those trigger points or dampen them down. Basically, I'm taking the body into a position of comfort. When I can feel tension release or there's a 0 to 10 pain, we're just going to hang out there. So you can always communicate with the client. And it settles down pretty quick right there. Good. Okay. Now, if I need to come back in, you okay there?
Yep.
Okay. Is it okay if I give that a little push?
Yep.
So take a deep breath in. Exhale. Good. So we're just going to unlock that one little segment. We're going to go one down. Deep breath in. So we do the rotation flexion. Less grimacy, more range of motion. So did compress some of the segments here on the right side. Now I can go back. Excuse me. Let's see if by changing the inputs around those segments, if it's taken or changed anything down below. So big toe up. This is where we got to check our work. Big toe down. Good. Foot up towards the ceiling. Good. So the bigger one, you might feel here. Hold. Hold. Okay. So it's changed something. Okay. All we did is we changed an input at the neck. We tested the lower extremity myotomes. They are a little bit affected when we were jamming them up into extension. Did some input changes with some soft tissue and manipulation. You can use towel mobilizations if manipulation is not in your skill set, but it's a nice quick hack to get in there. So now that we've got neck moving a little bit more. Now, Nick was also saying that he was doing some striking and kicking down and causing a little bit of irritation in the left knee. That's what I said. Okay. Now, looking at mechanics of his knee loves to internally rotate. Okay. You can see the kind of this posterior lateral corner really gets stressed. Now, if we're limited with hip internal rotation, and what he's describing is coming down and striking to use this tibia to cut down onto a quad, you got to rotate that leg down. Now, if his left hip doesn't rotate effectively, he could be trying to rotate down through this knee to try and find that angle that he's looking for. Now, the problem with that is he's got this hypermobile lateral knee, and now he's hitting it with these shearing forces, and they could be kind of punching out the back, causing some lateral knee irritation. So what we want to do is we got to get Nick's hip to internally rotate, so he doesn't want to turn at the tibia, and he can turn at that hip properly to drive it down and keep it locked and stacked so that forces go into the opponent and not into his knee. So when we're looking at the hip rotation, 45 to 50, 30 to 40. I'd say give him about 20. So we have to improve that hip rotation. Okay. Come over to this side, 40 to 50. See how much more rotation. He's got full hip rotation on this right side. So this left knee is just going to be a little bit more exposed to rotation forces. One, because it's a little hypermobile, and two, he's limited at that hip. Okay, because the hip's a rotation joint, this is not. So we got to get him into that left hip a little bit better. Cool. Now, if you flip over onto your tummy, you can check the hip and see if it's still limited here, because we've taken some of the fascial and the capsular tension off, and it's still limited. Okay, we want to see if it's truly capsular, which it is. Didn't change. We still don't have, we're limited with that internal rotation. External rotation, fine. Okay. Internal rotation, still limited. So we're going to say this is a capsular restriction. We have to go after this with a capsular key, okay, to unlock the body. Come over here, 40 to 50, okay, 30 to 40. That's actually pretty good. Okay. So we're going to come into the back of the knee. And you can see he's kind of jumping off the table. And anytime, and he's actually not too bad over here. Anytime there's kind of twisting forces at the knee, the little muscle in the back, popliteus, because it's a small flexor and a rotator to unlock the knee, and it sits so close, it loves to lock up. And it also attaches to that posterior lateral corner. And if this is toned up, and I can make him jump off the table, we got to shut that down. So we're going to use our PRT, positional release therapy. So Nick, what would you give that? 0 to 10?
That's probably a 4 or 5.
4 or 5. Okay. If I bring you here, 0 to 10.
Probably 4 still.
So 4. Okay. If we go here,
Same.
if I go out this way a little bit,
Be a 5.
5. We'll go worse that way. If I bring you up in a little bit way out rotation, what do we got here?
6.
6. Too far. Okay. What if I go into here?
Same.
6.
Yeah.
This way.
Same.
Same. Okay. So there could be something else turning this on. If I pop down into that calf, what do you got down here?
6.
6. Okay. So let's compare. Okay. So I got a 6 here. What is it up here?
So last maybe 4.
Okay. So if I push here, does that change the 6?
Yeah.
Okay. If I push here, does it change that 3, 4?
Makes it less.
Makes it less. Okay. So I'm going to go after this 6 first and then see if it affects that one. So let's do, okay, if I flex you, invert you, rotate you, 0 to 10, what do you got there?
Gone down, so probably 4 or 5.
4 or 5. If I take you a little bit more,
Same.
if I take you in, 0 to 5, 0 to 10.
4.
Okay. Oh, and it looks like there's a little fender bender in our parking lot. That sucks. If I take you out here, what about there?
4.
Okay. And way over here.
4.
Okay.
5.
5. Okay. So we've got some dominant trigger points here. Anything going on in that piriformis? Or not too bad?
Just tight.
Just tight. Okay. Let's see. How's that hamstring? Hold the leg. Don't pull. Good. Hold. Hold again. Any pain with that?
No.
No. So just checking internal, external rotation. So medial lateral hamstring. Hold the leg. Good. And hold. Oh, little spasm in the hammy. Oops. Okay. Hold the leg. Good. You okay there?
Yep.
Go. Check the glutes. Lift the leg up towards the ceiling. Hold the leg right there. Push up my hand. No, that's firing up. And hold. Push up. Okay, so manual muscle testing of the hip. Hamstrings are fine. Let's check kinetic straight leg raise. Lift this leg straight up in the air. Good. Go back down. If I hold here, lift it again. Harder, easier, no difference? No difference. Okay. So I'm applying inputs and then asking his nervous system, does it feel harder, easier, no difference? If it feels easier, then it's a desirable input. And the nervous system's saying, yeah, I like that. We should probably do something there. If it's no difference, nervous system doesn't really care. If it makes it feel worse, probably something we should avoid or not pay too much attention to. Okay. So let's do a little bit of kinetic muscle testing. Lift this leg straight up in the air. So we'll check the hamstring hip extension group. Point the toes. Push up. No, still okay. Check here. Relax the leg. Hold the leg, don't pull. Good. And relax. Don't push. Good. Hold the foot, don't push. Okay, so we might find something there. Flip back on your back. So hold the leg right there. Good, nice and locked in. Hold the leg, let me twist. Actually pretty good. Hold. Good. Until I push. Okay. So things are nicely locked in. Okay. But let's go back to the neural tension. Any problems with that?
It's a little, where your hand was tender. When you brought it up, it was a little tender.
Anything with that? Any pulling, any tension?
I guess back the knee.
Okay. And if I take that away?
A
little bit more. So tibial nerve is a little bit irritated. What if I take you over here?
Okay.
Not too bad. So we do have some entrapment. We're going to release that popliteus a little bit. So if it's not responding to the positional release, maybe we just have to come in a little bit more direct. So taking, he's gotten a lacrosse ball and a self-release exercise for the back of the knees that we went over. Okay. But if we're getting a little bit of sensitivity back in here, we're just going to release this a little bit more direct. Bend that knee for me. You okay? Yeah. If I rotate that way, does that change the pain at all? No. If I rotate this way? No, not too bad. Not too much. Okay. So I'm just doing a little bit more direct. Just kind of playing with directions of fascia. So I'm pressuring on, I'm rotating, I'm taking it up and down, I'm taking it side to side, and just seeing where it wants to go. And see if we can use the fascial system a little bit more to our advantage to kind of settle down some trigger points underneath. I'm starting to soften a little bit. So it's really important that you have multiple tools in your toolkit, because if you have one soft tissue technique that does a specific thing, trigger points, it can work great. But if it doesn't respond to that, having other tools, active release or myofascial release or any kind of other different approaches to change the input in the muscles and the tissues is always helpful. What are you feeling there?
Feels better.
Yeah, it's starting to soften up.
Yeah.
So I can start to feel it starting to soften under my fingers. So in this case, it just needed a little bit more of a direct approach to take down the tension. Cool. Okay. Right down. Okay. Relax, relax. Good. This was the hip that was more jammed up. So just by affecting the knee a little bit, which is cool and unusual, take away some of the tension on that trigger point, and now we have a little bit more internal rotation. I don't know. Sometimes just taking down a tension spot in a specific tissue, all of a sudden the nervous system just unlocks and restores. So we can say, well, maybe it wasn't so much of a capsule restriction. But this is why it's so important that we measure stuff in the beginning, we apply an input, we do our intervention, and we measure after. Because now we don't really have to go after the hip capsule, because for whatever reason, it just unlocked by releasing that popliteus. Very cool.